this, I'd like to call upon Dr. Easther Daziine.
Very good morning to everyone present here. Today I'll be presenting on periorbital necrotizing fasciitis masquerading chronic myeloid leukemia. So a 50-year-old female presented with generalized weakness of body for the past 6 months, also with generalized swelling of the face with bilateral periorbital edema for 3 days and areas of blackish discoloration of skin over both eyes, upper and lower lids for 3 days. So this generalized body pain and swelling for the last 6 months was also associated with loss of appetite and generalized weight loss. Also, she received injectable therapy comprising diclofenac, oxytetracycline, and dexamethasone over 2 days from a local registered medical practitioner elsewhere. Subsequently, she developed diffuse facial swelling predominantly involving the periorbital region, which was acute in onset, gradually progressive, associated with mild dull aching discomfort. So there is no significant past family or personal history. On general physical examination, she was emaciated and malnourished and febrile on touch, pulse rate and blood pressure was within normal limit. On ocular examination, we can see that the face is asymmetrical and there's diffuse facial swelling. Along with that, there is periorbital swelling and blackish discoloration of necrotic tissues over both upper and lower eyelids and both the eyes, which is more on the right eye than the left eye. Also, serous discharges were present over the eyelids. Also, we can see that there is blackish discoloration of over the right angle of the mouth, and head posture is normal. So the anterior segment, the rest of the it was normal, but cataractous changes were present. The rest were unremarkable. Posterior segment as well. So based on the clinical and the history and the examination, a provisional diagnosis of bilateral periorbital necrotizing fasciitis was made, along with the differentials keeping in mind of the acute drug reaction and cutaneous mucormycosis. So an intensive laboratory investigation was done to rule out toxic shock syndrome, also to isolate the etiology. So on this, hemoglobin, hematocrit, iron profile, and sodium was low, whereas white blood cell, C-reactive protein, erythrocyte sedimentation rate were raised, and platelet count, LFT, anti-nuclear antibody, and viral markers were within normal limit. So since the patient was debilitated, she was taken under the care of the internal medicine and was given broad spectrum IV antibiotics. Along with that, we also started topical antibiotics, lubricants, also ointment. Also, along with that, we also did urgent aggressive debridement of the necrotic tissue over both upper and lower eyelids, which was done, and this was continued every day. And these debrided necrotic tissues were sent for culture and sensitivity, KOH, gram staining, and that turned out to be positive for gram-positive cocci. So this is the debridement picture of the post-debridement day 3, the first picture, and the second picture is the post-debridement day 5, and the 7, we can see that there is no, on post-debridement day 7, there is no residual necrotic tissue, but there is healthy granulation tissue in the healing phase. So along with the debridement, the general condition of the patient improved, with hemoglobin improving to 10.3 milligram per deciliter. So on follow-up, the patient on the right eye developed cicatricial ectropion with conjunctival chemosis and exposure keratopathy, and in the left eye, wound healed with minimal function loss. Even up to this stage, there was no definitive diagnosis was made. And so to prevent the vision loss in the right eye, full thickness skin grafting on the upper and lower eyelids of the right eye was made. And the graft was harvested by wolf graft procedure from the front of mid-thigh. On the upper eyelid, it was taken well, but in the left in the lower lid, the graft couldn't take up and the graft retracted. And so since no definitive diagnosis was made, and there was deranged total leukocyte count, we also did bone marrow biopsy along with the collaborating with the internal medicine. So that revealed hypercellular marrow with marked granulocyte and hyperplasia and blast cells less than 10%, revealing chronic myeloid leukemia. So the ocular presentation, there was reduced proptosis with retracted skin graft, and the ectropion also decreased. And the patient was referred to oncologist for systemic management of chronic myeloid leukemia and advised for regular follow-ups at ophthalmology OPD for ocular monitoring. But she was lost to follow-up, limiting long-term ophthalmic and systemic outcome assessment. So my take-home message is that this necrotizing fasciitis is a very rare ophthalmic emergency, and this is most common in immunosuppressed individuals, especially the diabetics, and also can occur after even a trivial trauma. But this needs early diagnosis and prompt management, and this necrotizing fasciitis also underscores the eye's role as a window to systemic disease. Thank you.
I think those are beautiful slides. Any other differential diagnosis?
The differential diagnosis was their acute drug reaction and cutaneous mucormycosis.
Okay.
what was the age of the patient?
50 years.
50 year. So how was the timing decided for performing the skin grafting?
Sir, she developed cicatricial ectropion along with conjunctival chemosis and exposure keratopathy. So
Okay.
we plan for
And it was done after how much
around
duration?
2 months, sir.
Around 2
Yes,
months.
sir.
Okay. And why was thigh selected as the skin donor site? Why not the retroauricular region, which is most commonly used? Just asking.
Sir, it was more accessible in the mid-thigh area, so we went for it.
I think I would like to differ on that. Most likely, the most common site of transplant skin, the preferred site is retroauricular region. So, and possibly the reason might have been the size of the graft which was required.
The size of the graft was also large, so since we required it both for the upper and the lower eyelid.
And that blade is usually used for a split thickness graft rather than a full thickness usually. But
Sir, that, yeah, I think that's same.
the same. Okay. Otherwise, very nice.